like to thank the organization for inviting me to give this talk. And I will talk you about the second-line treatment in gastric cancer with a clinical case. I don't have any disclosure to declare. And our case is about a male, 43 years old of age, without any allergy. And as comorbidities, he presented hypertension and also hypercholesterolemia. In July 2011, he was diagnosed of a stage 4 gastric cancer because of multiple lymph nodes. In that moment, his ECOG performance status was 1. Here you have the workup that we performed. A gastroscopy that showed a deep ulcer in the lesser curvature that was biopsied, and the pathology report that tell us that it was an intestinal adenocarcinoma, HER2 positive because of an immunohistochemistry of 3+. Then the CT scan showed a thickening of the gastric body that was infiltrating the pancreas and the left gastric vein, and also metastatic lymph nodes, supra and infradiaphragmatic. Here you can see the pictures of the CT scan with a supraclavicular lymph node and also the big thickening of the gastric wall. The patient was treated with a first line during 9 months, from August 2011 until May 2012. He received 6 cycles of cisplatin, capecitabine, and trastuzumab, and then he continued with capecitabine and trastuzumab. The restaging after 3 months of treatment showed a partial response by RECIST 1.1. There was a decrease of the size of the primary tumor and also of the size of the lymph nodes. Then, the restaging after 6 months showed a maintained partial response, but unfortunately, after 9 months, there was a progression because of new hepatic metastatic retroperitoneal lymph nodes, as you can see here in that CT scan. So in that moment, and taking into account that the patient maintained an ECOG performance status of 1, what could be the next best treatment option for the patient? Well, the most of you will treat him with taxanes. As you know, metastatic gastric cancer is an aggressive disease with a 5-year survival rate less than 5%. Multiple phase 3 studies have shown that the doublet based on a platinum and a fluoropyrimidine is the best effective treatment in these patients, as Dr. Cervantes has presented before. Nevertheless, it has been with the addition with monoclonal antibodies that this benefit has been increased. In this case, in HER2-positive gastric cancer patients with trastuzumab. Actually, other molecular therapies are under investigation in this setting. But the prognosis for these patients once they are refractory is poor, with a median survival of 3 months. Here you can see the phase 3 trials with chemotherapy that have been performed in the second line. The first 3 ones compared best supportive care with the addition of a chemotherapy, either irinotecan or a taxane. The first one, the German study, although the little number of patients included, could demonstrate a benefit by the addition of irinotecan to the best supportive care. You can see that the median overall survival ranged from 2.4 months in the control arm up to 4 months in the experimental arm, the patients treated with irinotecan. The Japanese study also showed a benefit with the addition of chemotherapy, which could be irinotecan or paclitaxel. You can see also that the difference were significant in terms of overall survival. And finally, the COGAR study, which has been presented in ASCO this year, also showed that the addition of docetaxel to the best supportive care is beneficial for the patients. You can see that the median overall survival ranged from 3.6 months in the control arm up to 5 months in the experimental arm. So with these studies, we can establish that chemotherapy is useful in terms of overall survival in this setting. The last study in the bottom is the Japanese study, which aimed to know which of both chemotherapies was better. And although you can see that maybe in the group with weekly paclitaxel the survival is better, the difference in the two arms were not significant statistically. Here you have the phase 3 trials performed in this setting with target agents. The first one was negative. Everolimus did not offer a benefit in terms of overall survival for this kind of patients. The second one, the REGARD study, which has been updated in the previous presentation, showed a benefit with the addition of ramucirumab in that group of patients. The median overall survival ranged from 3.8 up to 5.2 months. These two studies tried to show the efficacy of a monoclonal antibody in monotherapy. The last one, the TITAN study, tried to show that the addition of lapatinib to paclitaxel in those HER2-positive patients wasn't beneficial for the patients. You may note that the control arm was with paclitaxel. And then, taking into account all the patients included, that were all FISH-positive patients, there were no difference between arms. But if we took only the patients with a HER2-positive defined DUAN immunohistochemistry of 3+, this benefit was observed. The median overall survival ranged from 7.5 months up to 14 months, and these differences were statistically significant. Here you can see some ongoing randomized phase 2 trials in this setting. Ones with chemotherapy, combining different kinds of chemotherapy, and in the bottom with target therapies. And then here, some ongoing non-randomized phase 1 and 2 trials, combining different kinds of chemotherapy, target agents, and finally immunotherapy. Going back to our case, the patient received a second-line treatment with irinotecan for 6 months, from May until October 2012. He developed only mucositis grade 2. The restaging after 3 months showed a stable disease, but unfortunately, after 6 months, a progression was documented. It was an increase on the primary tumor and also on the retroperitoneal lymph nodes. In that moment, the patient still remained with an ECOG performance status of 1, and he initiated hematemesis grade 2. So now, and taking into account his ECOG PS status, what could be the next treatment option? Well, the most of you say ataxan. As the patient had hematemesis, he received first hemostatic radiotherapy. But then, after the radiotherapy, what would we do? What should we try? So the patient received a third line with docetaxel. He developed neutropenia and mucositis grade 1. Then the patient, the restaging after 3 months showed a progression disease because of the apparition of new liver metastases. Oh, no. Then now, the patient still was with a ECOG performance status of 1 and had received a platinum, a fluoropyrimidine, trastuzumab, taxans, and irinotecan. So now, what could we offer to the patient? What do you think? So that's true. The patient go into a clinical trial. In this case, this clinical trial, he has started on May 2013, this May. And this is a phase 1 open-label dose escalation study that aims to estimate the maximum tolerated dose of this drug, LGM716, which is a fully human monoclonal antibody that binds HER3. HER3, as you may know, is a member of the epidermal growth factor receptors. You know that HER3 is catalytically inactive, so it's not found to be mutated or amplified in cancer. And HER3 is implicated in the pathogenesis of several types of cancer because of the heterodimerization. HER3 also has been shown to offer resistance to EGFR and HER2 target therapies. Thus, we think that inhibition HER3 in those HER2 positive patients may decrease tumor growth. Thank you very much for your attention.
Thank you, Dr. Alston.